All right, guys, let's, in this section, we're going to talk about knee osteoarthritis, or what we also know as the arthritis that is a wear and tear. When we're looking at the picture here, this is a great example of everything that can start to occur as we go through knee osteoarthritis. So we'll see that there starts to be cartilage loss. If there's cartilage loss, then that starts to narrow our joint space. So we see in the healthy joint, there's actually nice space between the two bones in that area, and there's nice fluid that helps lubricate our joints, and we start to see that there's a breakdown in cartilage. There's joint space narrowing, so both of the tibia and the femoral condyle will start to compress on one another, and then we'll start to see these bone spurs start to form, and all of this can become very painful for our patients. And if you look at the picture on the right-hand side, I think we can all understand why this is a very painful experience to go through. And we'll see different stages for our patients as they go through the disease process. So OA is actually the most common articular disease in the developed world. It's a leading cause of chronic disability, and millions or probably even billions of dollars are spent on the treatment of osteoarthritis. I read in one study that it showed on average someone with osteoarthritis costs the healthcare system upwards of $3,000 a year. Is mostly a consequence of knee OA and or hip OA, that chronic disability. Who are we talking about that we would put under the umbrella of higher risk, or who the demographics are? 33% of people 63 to age 94 are affected by osteoarthritis. More severe osteoarthritis occurs after the age of 55 and predominantly in female. Although knee OA can occur earlier on. We've talked about conditions such as patellar dislocations that can actually lead into knee osteoarthritis, or even if you have torn cruciate ligaments or collateral ligaments and trauma into the area, or you experience stress fractures, those can all lead to degradation of the knee and actually just maluse of the knee and the knee joint. So there's a lot of factors that can go into it, but we know that it's pretty predominant in that. We are going to look at that there's intrinsic factors and there's extrinsic factors to the knee. Natalie wants to say hi. Say hi, Natalie. Want to say hi? Mommy's recording right now. Okay, so intrinsic factors are, there's a genetic predisposition, age, so those over 55 and female would be our intrinsic factors. Those are factors that we can't change. And extrinsic factors would include obesity, trauma. So we've talked about patellar dislocations, that would be trauma, maybe severe accidents, maybe there's an accident in which they fell from a height and had to land. Repetitive knee trauma, so those we're going to consider that have had numerous injuries to their knee. You know, those that have had, I had an ACL reconstruction, and then I've actually had 2 additional reconstructions since then. We're going to consider muscle weakness, because if we have muscle weakness, now we have poor attenuation of the way in which the joint should be working. Joint laxity, mechanical forces, so those that have a job, or and we can say a job, even that leading into pro athletics, where there's a repetitive squatting or increased kneeling. So I think about when I worked in the hospital, those patients, or those jobs, I was buddies with one of the construction workers, and he was always on and off of his knees, and So just kind of thinking about that, eventually that might turn into some osteoarthritis. And then those are meniscal injuries, which we understand that meniscus helps in the cushioning and the separation of the two bones. And so that might lead to more risk of osteoarthritis later on. So what are our patients going to say? They're going to say that they're going to have pain in the morning. It will be stiff in the morning. That they like heat. So once they get into the shower, they actually feel better. They're going to like some motion, but not a lot of motion. There's going to, as a disease progresses, be persistent knee pain, and it's going to be diffuse throughout the knee, so there won't be one specific spot that they point to. They're going to complain of reduced function, and so really understanding that those are key components to the diagnosis of OA. This was given to us by Euler as well. They might also have catching and locking, especially as that cartilage starts to decrease or if they've had previous meniscal injuries. And then crepitus, so that kind of crunching sound in the knee. They'll complain of that as well. Objective, what are we going to see? There's going to be swelling that might be visible and might actually be pitting at some point. Because of the bone spurs, we might see some bony enlargement. There's going to be tenderness along the joint line, and it's not always medial or lateral. It can be kind of throughout that whole joint line. So we put this into the anterior knee pain, but you're going to see that patients might really complain of just medial joint line pain. They might complain of lateral joint line pain. So we're going to know that there's other factors that go along into the diagnosis of knee osteoarthritis. They're often going to have an antalgic gait, so that Trendelenburg. We're going to see an increased incidence with genu valgus, so especially in complaints of the medial compartment. We'll see loss of knee flexion and then extension, so following the capsular pattern. And then really they will have that inability to weight bear through there. They will start to really limit themselves. They'll prefer the sagittal plane for stability. As the disease progresses, they'll lose that transverse plane mobility. So what are treatments? A lot of times our patients will go in to see an orthopedic doctor, and one of the first things they'll do is injections. So they'll do cortisone injections. And then if they are entertaining surgery, if the disease has progressed to be severe and debilitating, then they're going to consider a total knee arthroplasty. They might also do a joint lavage or arthroscopic debridement. This would be in the earlier stages of OA. They could also look into joint preserving surgery, so osteotomy, so not such a significant surgery as a TKA, but kind of the precursor to that. Pharmacology, what are they going to do? NSAIDs, a lot of them you will hear taking Aleve and ibuprofen on a daily basis. Even topical NSAIDs, so using topical creams to help with that. They might get on Cymbalta, and then they might end up into where they're now using a stronger painkiller, so opioids or narcotic analgesic. This is tough. It's a tough scenario once we enter into this. They're definitely into a pain cycle. There's a fear avoidance that we're going to have to talk about with our patients and really incorporate into our training. Natural supplements, their studies show that if you have a deficiency in vitamin D, you have an increased risk of osteoarthritis. Turmeric is a natural anti-inflammatory. And then glucosamine has been studied, but there's really varied results. Some people will try it and have great results with it, and other people it really does nothing for them. So what do we do? Well, one, we're going to have to talk with our patients about activity modification. So let's say that they have osteoarthritis, but they're still walking 10 miles a day, and they have that antalgic gait, and so now we know that there's issues at the knee, but we know it's going to go up and down the chain. So we want to do activity modifications right away. And then once we get them into a better functioning state, then we can start to add in increased duration or increased load. Shoe wear is going to be very important. Again, we want to examine the position of the foot. Are they pes planus, pes cavus? What is that doing to the knee joint? Does it correlate with where their knee osteoarthritis is? So really looking at, are they wearing too thick of shoes? So I've had patients that wanted to try those Skechers shoes that came out a while ago where they're really walking on about 1.5 inches of foam, and so all it's doing is throwing them into the frontal plane and the transverse plane and just creating more issue on their knee. So that would, we're not always going to, they need to be in an orthotic or a stability shoe. We're just really, we have to examine, is that shoe appropriate for the patient? Obesity is a high risk factor and a large component to knee osteoarthritis, so getting our patients into a weight loss programming would be great. De-weighting exercises, if our patients are pretty severe, aquatic therapy would be a great place to start, or body weight supported treadmill training. We're going to use our manual therapy. Exercise actually has been shown to be very, very highly effective for our patients with this, as long as it's not too much. That's why combining our manual therapy with exercise will be a really great way to affect our patient overall. When we do our manual therapy, we're going to look at the mobility of our hip. So please don't forget that. Even within exercise, are they stable within that hip, creating stability throughout the knee? We want to limit our joint compression and rotational components until later stages. We can use kinesiotaping for proprioception, for alignment, for decreased compression at the area. We can also use our modalities of heat, e-stim, and laser to affect the area.